this pattern is somewhat common in our patient population. And it's very interesting because all of the testing on the upper pelvis are normal. Only when you test the lower part of the pubic joint and of the pelvis do you encounter this pattern. I discovered it a good 25 years ago, and I named it left lower windswept pelvis. When you check the upper landmarks, they're all, they're all symmetrical, and all the upper spring tests are all normal. But when you come to the flat part of the ischium in the lower third of the pelvis, you'll note that the left one is towards the ceiling, okay? Furthermore, it will have blocked posterior to anterior PA spring, whereas the right side you can load it and you can spring it. Now, this doesn't always come with the lower pubic rotation. Half of them do approximately, the other half don't, of course. So if you come onto the pubic bones, allowing about a 1/4 inch for the fibrocartilage, you come and you palpate the upper third, the middle third, and the lower third, and that's where you would see a big difference, about a 1/4 inch, in which this left lowest third is more posterior, okay? The other findings are that the midline crease of the buttocks is here, and the left ischium is more lateral that way, okay? And this guy's not very flexible, so I'm going to get a different model. This one has more mobility. Good. So in comparison to the midline, this ischium is more lateral, okay? And when that happens, okay, and my belief is that the right is also more medial than normal, okay? And if I do any of 4 spring tests, they will all be blocked. So I'm springing on the left side of the ischium going to the right, it's blocked. And if I come in and I try to push the right ischium to the right, it's blocked. And then if I come this way and I try to push right ischium medially, it's blocked, and left ischium laterally to the left, it's blocked. But there's no reason to do 4 of those tests because you've already picked up on the pattern, okay, several positive findings. And if you just do 1 of those spring tests, bingo, it doesn't move, and then you know that's a treatable pattern, okay? Let me just think in my mind a little bit. Okay, the last part of that pattern I'll talk about shortly, but it's basically like the ischia not only side bent to the left, okay, but they also rotated in this manner, okay? So it's side bent left, and the front of the ischia rotated to the right, okay? And so these ligaments are tighter on the left side. The sacrospinous ligament and the sacrotuberous are tighter, so you can compare the ligament tone, and they're definitely tighter on the left. They can pull the coccyx into left, pulling the tip to the left, and also rotating it so that the left side of the first coccygeal segment is more posterior, okay? Treatment is very simple. It's typically a once and done, okay? You treat them once, stage corrected, all right? I do teach some stretches. You can see the section on home program. Just for 3 days, I have them do simple stretches to reinforce it. But basically, as the book shows you, the first thing that you do is you take a 2x4x8 piece of foam, and it goes horizontally immediately underneath the lower third of the pelvis. So it's under the ischium. So if I bend my knees here, okay, and then I pick up my pelvis and slide it in, and then straighten out my leg, we're home. That's it. Okay? It's a rather dense joint. I used to do it for 5 minutes, but I'm starting to do it for 3 minutes, and it works just as well. So I encourage you to do that for 3 minutes. And it's never failed me in correcting a lower pube rotation. So after you do that, if you wanted to, you could get them prone and see if the spring is restored. It will be. But it's still prominent, and the ischium springs now, but it's prominent. Why? Because it has that rotational, transverse plane rotational element. Okay? So in the book, I show you, I'm sorry I don't have a live person on the table here, but actually, can I get you on the table, my videographer? That's my wife, Karen. Come lie on your back. Okay, so what I do is, remember, you want to bring the left ischium closer to the midline, and then the right ischium more lateral. So I bend the right knee and I cross over and put the foot flat and just hold it there. I get the slightest inferior traction. Anytime you want to stretch or move a joint, it's really nice if you can traction it. Okay, so I just pull it down ever so slightly, and then I bring it towards me, and I just want to be extremely gentle, and that's her barrier, so I'm not going to push it at all. I would just hold that for 2 minutes, and then when you let go, you want to let go very slowly and just tell them, okay, we're done with the stretch. Bring it back, okay? And then we stretch the right adductors so the leg is straight, and you just gently bring the leg to the outside, taking it into abduction, and you take it to that natural barrier. It's nice to go slowly. People will be more able to relax. And right there, I'm close to the barrier, so I'm going to stop right there. Hold it 2 minutes, okay? And now, you need to lay on your stomach. Let me take your glasses. Okay? All right. So now we want to rotate the front of the ischia to the left, okay? On the right side, we take the hip, we bend the knee at 90 degrees, and we just very gently take the hip into internal rotation and hold it there. Okay? Then we take the left one, okay? And then we're just going to take it into external rotation towards the barrier, and then we just hold it there gently for 2 minutes. Okay? And then we straighten out, and now is a real good time to do a medial spring test on the left ischium. And if you can load it to a stop, and then you can spring and get spring and recoil, you're done. But you still, at that point, you want to put your thumbs inside the medial aspect of the ischia, and if it still looks like a windswept pelvis, that is an indication that they have developmental asymmetry that you're not going to change. And that's when you go into a sitting evaluation to find out if they need a little support under a trochanter or a little piece of craft foam under a sit bone. And there's a section in the book, it's quite wordy, but you can also just go to YouTube, I will give you that link, and find the video called Enhancing Sitting Comfort. So you go to YouTube and you type in my last name, H-E-S like Sam, C-H, Enhancing Sitting Comfort. My clients find that to be very, very valuable. And 30% of the population have bony developmental asymmetry that we can't change. And there were 2 very good studies done 20 years apart, and they both validated the same thing. And similar things can be said about the hip. So I really encourage you to look at that section. So now we've improved everything, and so now we get to retest the tailbone. And so you drop your middle finger just about right at the top of the lower third, and that's your tailbone right there. So I'm going to come on each side, allowing at least an inch between my index fingers. Okay? Now hers is symmetrical, and sometimes balancing the lower pelvis, the tailbone straightens out. Okay? But otherwise, if your right index finger in that little sulcus of the coccyx is higher, that does indicate a side bent coccyx. You don't have to do the spring test. We do show it to you, but you've had all these antecedents, so we know it's going to be blocked if you did the spring. And so the treatment is to take, I like to wrap my thumb, bend my thumb, and contact as much of that tailbone as I can, bring my other thumb this way, and then engage it with about 5 pounds of force. Okay? I like to do it for 3 minutes. And then I come and engage these ligaments, especially sacrospinous, and I just load them very gently, and I just stay there. And the reason I like 3 minutes, for one thing, it's very, very effective, but the pelvic floor muscles are also involved in this, along with the ligaments, and I just want to really optimize the treatment. There are times when 2 minutes will work. You can experiment with it. Okay? And then you come off, and then you retest it, and if the sulcus are equal, beautiful. Now you need to look and see if there's a rotation. So the first coccygeal segment, CO1, is the biggest segment. This one. And it has the little transverse process, and this guy certainly has odd development, asymmetrical development. But the coccyx might still be rotated. So the front of it faces to the left, so we call it a left rotation, and the left part of the first coccygeal segment is more prominent, and it doesn't spring with just one thumb spring. Okay, so I come back and I find the tip of the tailbone. I come up on both sides, okay, and then I just come up a little tiny bit, a half of a thumb width, and I put my thumbs there and compare, okay? And hers is symmetrical, and with my thumb, I can load it gently and then give it a little spring, and the motion does translate through that. Otherwise, you just take the heel of your hand or a thumb, and you just pull it a little bit inferior to get some distraction, okay? So you could do that symmetrically, a little bit of inferior traction for about 30 seconds, and then you lift up the fingers, and now I'm just leaning on the left side of the upper coccygeal segment. It works beautifully. And then you retest in the same manner and have them sit. And quite often they notice a very distinct improvement in their sitting. And I retest them a week later, they're still doing fine. So I call it a once and done. And of course, now any soft tissue work you do, it's going to pay dividends because we've balanced structure, we've improved the local neurology, and so now we go into the soft tissue and the body is just very, very responsive and long-lasting benefit. So I'll stop here. Thank you very much.